Right. So this is the outline of the talk. So I'll briefly talk about the global prevalence and incidence of NAFLD and NASH, for the NAFLD epidemiology in India. And I will touch upon lean and non-obese NAFLD, because this is one of the groups that could be missed out if we switch over to a NAFLD definition. And the fact that NAFLD is emerging as a leading cause of clinically significant liver disease worldwide and in India. And lastly, the future estimates. So this is the meta-analysis of 2016 by Zubair Younussi group, which showed us that almost a quarter of the global population have underlying fatty liver disease. What this meta-analysis also tells us is that the highest prevalence is in the Middle East and the lowest prevalence is in Africa. What about NASH prevalence? The same meta-analysis found 15 studies, and they said the pooled prevalence of NASH among patients with NAFLD was a whopping 59%. The reason, the caveat, the catch behind this finding of very high NASH proportion is that most of the included studies, they included patients who had been specifically referred to undergo a liver biopsy. So the pretest probability of them having underlying NASH, because they were referred for biopsy to see if they have underlying NASH or not, it was very high. And that is why the NASH prevalence was high in these groups. But if you look at other studies where biopsies were performed on random or on a voluntary basis, not for a specific purpose of looking for NASH, there the proportion of NAFLD patients who have NASH would range from around 6% to 19%. So what's changing in the global prevalence? After the Younussi meta-analysis, we have this meta-analysis in clinical gastroenterology, hepatology of 2019. And what it says is the pooled prevalence has now risen to almost 30%. In fact, if we use only those studies that include ultrasound, the prevalence would be even higher. And there's a significantly higher prevalence in studies that have been published after 2016 as compared to those that were published prior to 2016. And now the highest prevalence zone appears to have shifted to South America. And what is the trend? There is a trend of the NAFLD prevalence is going up and up if you look at the data from 1990 till 2020. And it has increased from around about 20% to almost 38%, with the most rapid change being observed again in South America and Europe, which could have something to do with the Andean diet that is followed in South America. This translates to an annual increase in the prevalence by almost 1%, that's 0.7%. However, there has been no change in the phenotypic risk factors of NAFLD. In other words, NAFLD still continues to remain the most common in patients who are obese or diabetic or who have other metabolic syndrome risk factors. So this is another meta-analysis that included around 150 studies with more than 1 lakh participants to look at the overweight and obese individuals. So the overall prevalence of NAFLD is almost 70% in overweight and obese individuals. And NASH, almost 1/3 of overweight or obese patients would have underlying NASH. But if you look at obese patients who have NAFLD, in that group, the obese NAFLD group, almost 50% would be having underlying NASH. The worrisome thing is that obesity is in various countries. So in all these Asian countries, we can see that obesity has gone up by almost 2 to 3 times over the last 15 years. And it's expected that the NAFLD prevalence will parallel the surge in the rise in obesity. Again, in diabetic group, the meta-analysis of almost 80 studies with around about 6%, so 56% of patients with diabetes have underlying NAFLD. What about the incidence of NAFLD? The data is very scarce and it predominantly comes from the Oriental Asian countries. And overall, it's about 50.9 per 1,000 person years. That's around 5 cases of NAFLD per 100 person years. However, note at the I-square statistic, which indicates there's a lot of heterogeneity in the available data. Is the incidence of NAFLD also increasing? I've already shown you that the prevalence of NAFLD is increasing, but that could be simply because of the fact that nowadays people are living to be older age, so the prevalence is going higher. What about the incidence of NAFLD? We have this 20-year community study from Olmsted County in the United States. And what we can see is that over the past 15 years, from 1997 to 2013, the incidence of NAFLD has gone up almost 7 times. And further worrisome is that the age group in which the incidence is rising the most rapidly is the youngest age group of below 40 years. Now, coming to the burden of NAFLD in India, the overall pooled prevalence of NAFLD as determined from 50 studies, including of adult patients, is around 39%. Obviously, the prevalence is much higher in the higher risk groups like obesity and diabetes. So although I have not shown the data, the ICON-D study would show that almost 73% of the patients are overweight and 17% are obese. So only 10% are lean. Again, we have the SPRINT study, a multicentric study of more than 100 cities, which show that in diabetic individuals, NAFLD is present in more than 50% patients. I would like to draw your attention to 2 peculiar aspects of the epidemiology, relatively peculiar aspects of the epidemiology of NAFLD in India. Number 1 is the regional variation. So if you look at the prevalence of NAFLD in the different regions of India, it appears that the prevalence is highest in South India and in North India, and it appears to be lower in Eastern India. This could be related to the diet, degree of urbanization, other lifestyle habits, etc. The second point I would like to draw your attention to is the prevalence in urban areas appears to be higher than that in the rural areas. So in this meta-analysis, what they found that there were 44 studies that included urban cohorts, and there the prevalence was 40% as compared to studies that included rural patients where the prevalence was only around 29.2%. This is a unique observation which we have also observed in Sri Lanka, but has not been observed in other Western countries or indeed even in our neighboring country of Bangladesh. The caveat with this is that this is a meta-analysis that has looked at different studies. There are very few studies that have looked at urban and rural population simultaneously. That is, urban and rural population has been looked at simultaneously in the same study. Those studies are very few. So we have the Trivandrum NAFLD cohort, which is published in BMJ Open a few years back. And what they found that in the whole district of Trivandrum, the NAFLD prevalence was around 50%, and urban domicile had a higher risk of having NAFLD after adjusting for various confounders. Again, we have this pure cohort, the prospective urban-rural epidemiology cohort that is being done in Chandigarh and Punjab. And there again, the prevalence in the urban communities was significantly higher at 54% as compared to only 30% in the rural areas. However, some contradictory data. This study looked at the prevalence of NAFLD in urban Delhi and rural Ballabgarh. Ballabgarh is an area in Haryana, a few hundred kilometers away from Delhi. And what they found that the age standardized prevalence of NAFLD was similar in Delhi and in rural Ballabgarh to be around 60%. So now moving on to lean NAFLD. I think this is an important group because if we change the term of NAFLD to MAFLD, many of these lean patients would be missed out. So it is important to know what is the burden of this lean NAFLD. Is it really so small that we can just completely neglect this as a group? If you look at it globally, then among the general population, around 5% would have lean NAFLD. In the general population who is lean, that is in lean individuals, around 10% would be having lean NAFLD. And if we look at the NAFLD population, then around 1/5 of them would be lean. The scenario in India is also kind of similar. So among the general population, lean NAFLD would be present in around about 6.5% individuals. Whereas among patients with NAFLD, around 15% would constitute as lean NAFLD. So the prevalence in the general community for lean and non-obese NAFLD would be around 5 to 10%. But if we look at NAFLD as a group, then among NAFLD, around 16 to 32% would be qualify as lean or non-obese NAFLD in India. So even though it is less, it is not there, and we cannot neglect this as a group. So as Professor Gurdas Chaudhary already told you that NAFLD has emerged as most important cause of one of the leading causes of chronic liver disease now worldwide. So this is the global burden disease of 2017, which shows that from 1990 to 2017, Compensated cirrhosis that is attributable to NAFLD has doubled. Decompensated cirrhosis that is attributable to NAFLD has tripled. And the age standardized prevalence of compensated and decompensated cirrhosis due to NASH has increased by 33 to more than 50%. In this diagram, I would like to draw your attention to these trend lines. So what this shows is that the age standardized mortality due to hepatitis B, due to alcohol, due to hepatitis C, and other miscellaneous causes are all decreasing because we now have got good antivirals. We're getting better and better at managing patients with cirrhosis. However, look at the age standardized mortality due to NAFLD. That remains persistent and is in fact showing a slightly higher trend, while age standardized mortality due to all other etiologies of cirrhosis is actually decreasing over the last 17 years. There's an increasing burden of hepatocellular carcinoma. So it's NASH is emerging as the leading cause of HCC slowly. And this is actually data from our own institute. And what we can find that prior to 2010, only around 15% of all the HCCs that we used to see were due to NAFLD. But now that has risen within 5 years to almost 20%. That's a jump of 25%. So 25% jump in NASH HCC over the last 5 years. So coming to future estimates of NAFLD. So this is a Bayesian analysis that took data from around 202 patients. And what we find is that annually, the prevalence of NAFLD is estimated that it will increase by 2% every year. And by the year 2040, more than half of the world's population will be having underlying NAFLD. Around 56% would be having underlying NAFLD. And the burden would be highest in Asia and Europe with more than 60% of the patients with NAFLD. This is another Markov model that estimated NAFLD and its various histologic spectrum in US patients by 2030. So if you look at the data in 2015, then there were roughly 83 million in the US who had underlying NAFLD, and among them around 20 million had underlying NASH. By 2030, the 83 million is expected to go up to almost 101 million. So by 2030, 101 million people would be having NAFLD, and NASH, that would again go up to almost 30 million from 20 million. What is even more important, I think, from the pathophysiologic point and the progression of disease point is that in 2015, only around 2 plus 1.3, that is 3.3 million people in the US had advanced fibrosis. This would go up to almost 8 million people by 2030. That's a jump in almost threefold jump in the number of patients with advanced fibrosis due to NASH in the US alone. This is another Markov modeling study which shows that the prevalence of decompensated cirrhosis, incident decompensated cirrhosis, liver-related mortality, and hepatocellular carcinoma will all go up tremendously over the years up to till 2030 in multiple countries around the world, not just in the US. So my take-home message is that prior to the turn of the millennium, even in the 1990s, NAFLD was considered to be largely an innocent bystander. Then we found that association with cryptogenic cirrhosis and cryptogenic HCC. And from that, we have now moved on where we are finding that NAFLD is the leading cause of liver-related morbidity and mortality, including cirrhosis, decompensated cirrhosis, and HCC. It is further likely to snowball into a bigger public health problem because of the ongoing pandemics of obesity and diabetes mellitus. Remember, India is the diabetes capital of the world, and both of these are going up. So the prevalence of NAFLD will also be going up. Incorporation of NAFLD into a national program appears to be a prudent and timely step. However, we really need to identify which groups need to be screened for NAFLD, because almost 50%, almost 40% of your population has underlying NAFLD. Who do you screen for NAFLD? And then if we identify that this particular individual has NAFLD, who is it that is really at risk of clinically significant liver disease and who need referral to specialists? Thank you, sir.